ಎಷ್ಟು ಜನ ಲಾಗಿನ್ ಆಗಿದ್ದಾರೆ?
Hello, good morning to everyone. Today we are going to learn about hormonal contraception. In this slide you can see many types of hormonal preparations which are used for contraceptive purpose. You see here these can be used as oral pills, which is the most commonly used one and popularly known as the pill. And the other alternative preparations available are subcutaneous implants, injectables, vaginal rings, patches, and Mirena. Mirena is, as we've learned in the last class, it is a LNG, a levonorgestrel intrauterine contraceptive device, which is used for as a long-acting reversible contraceptive method. Coming to the preparations available, these hormonal preparations can be used either as a combined form or as progesterone only formulations. The commonly used ones are combined. We have oral types, and it is available as contraceptive patch and injectable, and a newer ring, which is also a combined estrogen progesterone formulation ring. And progesterone only preparations are mini pills and injectables, and these methods are used as emergency contraceptive pills also. And we have another recent contraceptive preparation which is anti-estrogen, which is arminolocsifen, centchroman, also known as centchroman. And this is not very commonly used as a contraceptive, but more of it is used as an emergency contraceptive method. And coming to combined oral contraceptive pill formations, the commonly known is the pill, which is the most reversible and reliable method of contraception, and it is widely acceptable and it is most effective. And the government of India approved in 1951 for the purpose of family planning in the National Family Planning Program. And it contains estrogen and progesterone components. Estrogens in combined pills are of two types. One is the common one is ethinyl estradiol, and the less common one is mestranol. The progesterone in combined pills used are grouped into different generations: first generation, second generation, third generation, and fourth generation. First generations, and it contains norethisterone, norethisterone acetate, and ethinyl diacetate, linestranol. And the second generation contains levonorgestrel. Third generation contains the better ones, desogestrel, gestodine, and nargestimate. And the fourth generations are draspironin, which is an anti-mineralocorticoid and anti-androgenic progesterone component. So these are classified based on their progestational activity and anti-androgenic property. The first generation are less progesterogenic and more androgenic, and vice versa in the fourth generation. They are more progestational and more anti-androgenic. Because of these potency, they are graded into different generations. And the newer ones available are others like Dynogest and cyproterone acetate, which are used in certain indicated conditions where we require anti-androgen properties. Like cyproterone acetate is used in polycystic ovarian disease, and Dynogest is used in cases of endometriosis and fibroid cases where we require to antagonize estrogen properties by progestational activity, highly potent progesterones like Dynogest. And combined oral contraceptive pills are again classified into generations, first, second, third and fourth generation, depending on the dosage of estrogen which contains. The higher the dosage, more complications. So the first generations used to contain 50 micrograms. These are rarely used nowadays except in cases of certain cases of puberty menorrhagia. Otherwise, they're almost obsolete because of the complications, and the second, third, fourth generations use lesser strengths of estrogen. Second and third are called the standard ones, which contain 30 to 35 micrograms of estrogen with levonorgestrel or gestodin and desogestrel. These are the commonly used ones. Fourth generations are containing less than 20. So they are low dose, called as low dose pills, and they are also less commonly used except in cases where it is indicated to give smaller doses of estrogen. And these oral contraceptive pills are also classified based on the concentration of estrogen, progesterone, and in different phases of the cycle as monophasic pills and phasic pills. Monophasic contains same strength of estrogen and progesterone in all the tablets of the pack, let it be 21-day cycle pack or 28-day pack, and there is no change in the strength or the concentration of the estrogen and progesterone. The commonly available one is Mala D and Mala N, which is available through Government of India, free of cost. Mala N contains 28 tablets, among which 21 are active and last 7 are inactive, containing iron. And these contains levonorgestrel 0.15 milligram and ethinyl estradiol 0.03 milligram, and D is nothing but D-levonorgestrel. That is the only change between Mala N and Mala D. And in multiphasic pills, the concentration of estrogen remains same in all the pills, whereas concentration of the progesterone varies according to the days of the cycle. It is available in biphasic form and triphasic form. In India, biphasic tablets are not available. Triphasic form tablets are available. Commonly available is the one which is called as Triquilar. That contains estrogen, as I already said, in a fixed dosage, that is 0.03 milligram or 30 micrograms. And levonorgestrel strength varies from day 1 to day 6, it is 0.5, day 7 to day 11, it is 7 to 11, and day 12 to day 21, it is 0.125 milligram. The advantage of varying the strength of this progesterone is that better cycle control and better efficacy, because the breakthrough bleeding, other menstrual the bleeding problems are due to progesterone, and which can be better controlled with the variations in the dosage. Advantages are high efficacy, few side effects, and less breakthrough bleeding, as I already told, and they do not increase the serum cholesterol and lipids. Disadvantage is that because the tighter control, tighter dosage, if they miss one pill also, there is highly failure rate and the pregnancy rate. The newer OC pills which are available in the market are Yasmin and Yaz and Diane and Freedays 30. Yasmin is the one which is available for the patients with PCOD, because it has got Draspironin, which is an anti-mineralocorticoid, spironolactone analog. It has got anti-androgenic and anti-mineralocorticoid activity, and it has got the advantage of weight loss, which is the desired effect by the women who are using contraceptive pills, because there is a tendency for water retention and weight gain with other tablets. So this is a welcome tablet for many women. Because of anti-androgenic effect, this is used also in cases of PCOS, hirsutism and acne. And Yaz is similar to Yasmin, but it has got 28 tablets with less pill-free period of 24 days of active pills and 4 days of pill-free. And Diane is the one which contains ethinyl estradiol with cyproterone acetate. It's a progesterone with anti-androgenic activity, again used in hirsutism, acne, and PCOS. 3 days ethinyl estradiol with the dimogest, which is recent, and it has been used in cases of fibroid and endometriosis because of the desired effect. Mechanism of action is through inhibition of ovulation. Estrogen prevents LH or FSH surge and prevents formation of a Graafian follicle, and LH prevents and progesterone prevents LH surge, thereby inhibiting ovulation. Endometrial changes, which results in stromal edema, decidual reaction, and regression of the glands, resulting in atrophy, which becomes unresponsive to embryo implantation. Cervical mucus, which becomes thick, viscid, and scanty, which impairs penetration and transportation. And because of the progesterone, there may be tubal motility is impaired and alteration in the tubal transport of the egg or the embryo, that resulting in the protection. And the benefits of oral contraception the first thing is they're highly effective. The pregnancy rate is 0.3 per 100 women years for a perfect user. And I explained in the last class what is a perfect user and what is a typical user. Perfect user is the one who uses the pill without fail on any given day. The typical user has got a history of missed pills, and it is very good with the perfect user with the 0.3 per 100 women years, and it can be used in cases of hyperandrogenism. I already explained, and prevention of ectopic pregnancy, some protection against PID, and mainly this is useful in cases of amenorrhea, dysmenorrhea, and menorrhagia because of the reduction in the blood flow and relieve the premenstrual syndrome, and it is protective against endometrial cancer, cancer of the ovary, functional ovarian cyst, and benign breast disease. Protection against CA ovary is very well established because it is going to prevent ovulation, thereby protects against CA ovary. Protection against osteoporosis and rheumatoid arthritis because of the estrogen component in the combined oral pills. Non-contraceptive uses because of the already discussed non-contraceptive because of the benefits. It can be used in conditions like BUB, endometriosis, hirsutism, PCOS, dysmenorrhea, premenstrual syndrome, and other menstrual disorders like hypothalamic amenorrhea. Hormone replacement therapy in perimenopausal women and postmenopausal women, and in hypogonadism. Side effects are major and minor. The commoner one are the minor ones, like any other tablets. When they take it, is nausea, vomiting, lack of appetite. And common with OC pills are breakthrough bleeding, menorrhagia and irregular bleeding in the initial phases of the usage, and oligomenorrhea and amenorrhea in the long-term usage. Breast changes, which is again due to progesterone and water retention, vaginal discharge due to cervical erosion, leukorrhea and vulvovaginitis, headache, migraine, asthma, weight gain. All these you can think and answer. Every system will be affected, but the benefits outweigh the risks of using the tablets, so these are commonly used. And major side effects which should always keep in mind are venous thromboembolism because of the usage of estrogen, and hemorrhagic stroke, ischemic stroke, and myocardial infarction, hypertension in women who are more than 35 years and smokers, gallbladder disease. The usage of combined oral pills are associated or linked with the development of breast cancer, cervical cancer, because it doesn't give protection against HPV infection as in cases of barrier methods, and hepatocellular carcinoma, though rare, the cases have been reported. So we should be careful when prescribing combined oral pills with the history of all these. So interaction with the drugs, we should be aware when we are prescribing combined oral pills for the women. We should be aware that women who are taking barbiturate sulfonamides and rifampicin, they do have effect over the liver metabolism, and they increase the production of enzymes and thereby reduces the bioavailability of pills. So we need to advise the woman to use additional contraception. And interaction with the anti-diabetic drugs and women who use vitamin C will have aggravated effect of combined oral contraceptive pills. And now who can use combined oral contraceptive pills? In the beginning of the contraception class itself, I told that WHO has given eligibility criteria category 1, 2, 3, 4. Category 1 with no contraindication, category 4 with absolute contraindication for each method where they cannot use. 2, 3 are relative contraindications where a woman can use the methods provided no other alternative methods are available, and knowing the risks and benefits outweigh the risks in category 2 and 3. Coming to combined oral pills, category 4 is the one with the complications like high BP or family history of breast cancer, or family history of cervical cancer, or venous thromboembolism. Those cases we cannot advise them to take combined oral pills. Category 1 with the benign breast disease, uterine fibroid, where it is a non-contraceptive benefit is expected, we can give them without any second thought. You can give the tablets to these women. And what are the contraindications? Absolute contraindications, as I already told, that is WHO category 4 with cases of migraine and pregnancy and breastfeeding, hypertension, thrombophilia, smoker more than 35 years, complicated valvular heart disease, diabetes more than 20 years with vascular complications, hepatitis, like all the organs you think and read. Some common ones are major surgery, women posted for major surgery, even she was taking, we should stop at least 1 week prior, and where after surgery prolonged immobilization is expected for the risk of thromboembolism, and cerebrovascular accident and thrombophlebitis are some of the other major contraindications. Where we can use the tablet with caution are liver disease, asthma, acne, hirsutism, migraine, diabetes, hypertension, optic neuritis, convulsive disorders, sickle cell disease, obesity, cholestatic jaundice, BP more than 140/90, and women with rifampicin, where we have to be aware of the drug interaction. The indications when to withdraw the tablets, like when they develop complications like severe migraine, visual disturbance, sudden chest pain suggestive of MI, or unexplained fainting or vertigo suggestive of strokes and hemorrhagic stroke, or severe leg cramp suggestive of DBT, excessive weight gain, depression prior to surgery, and when patient wants to become pregnant, we need to withdraw the tablets. Selection of patients taking history of all those indications and contraindications, family history of all those you have to take, and thorough examination of the breast to rule out any breast mass, blood pressure to rule out hypertension, pelvic examination, and simultaneously to take cervical cytology, and the last menstrual history to know the last menstrual period, rule out pregnancy, and whether she's lactating or not, age, cigarette smoking, all these high-risk factors to be evaluated in history and examination. Then we have to advise her to take the tablet, how to take a tablet if she's a new user. And we have 2 types of packs available, 21 tablet pack which is available commercially, and 28 tablets pack available through Government of India, Mala D and Mala N. If she's taking 28 tablet pack, it is actually 21 active pills and 8 inactive pills. In that, both the cases she has to take on the first day of the cycle. In 28-day cycle, she will take till last day, but she'll have the withdrawal bleeding in the last 7 days. And there is no break between the pack, and she will start the next pack after the completion of the first pack, that is on day 29, irrespective of bleeding. 21 tablet pack, there is 3 weeks on when she is taking 21 tablets, 3 weeks on, and 1 week off when she is off the tablets and she is expected to have withdrawal bleeding. irrespective of the bleeding, she will continue to take the second pack from day 29. And for a lactating woman, where we give only progesterone only pills after 3 weeks, and if we are giving combined pills, it has to be given after 6 months. And after abortions, immediately, or we can give up to 7 days. And if she is amenorrheic, you can start on any day, but after ruling out pregnancy and advising barrier method for another 7 days. And this is the common problem when the women are taking combined pills. There is a problem that there is always a chance that they miss the pills. So this, when they come with a history of missed pills, what to advise them? So if a woman is taking 30 to 35 microgram of ethinyl estradiol pills and she misses 1 or 2 tablets, no need to panic. She should continue to take the next the tablets as per the dosage schedule, pack schedule, and as soon as she remembers, she should take the missed pills also. And if she has missed only 1 or 2, she need not use additional protection or emergency contraception. If she has missed 3 or more, definitely she needs to have additional contraception in the form of barrier methods or emergency contraception. And but she should not miss the pills what she has already missed. She should take the most recent missed pill as soon as she remembers, and she should continue to take the remaining pills as her usual time. If she is missed in the 3rd week, she should on a 28-day pack, she should not use the inner tablets. She should start with the second pack without giving the break. And if she is using a 21-day pack, she should not go for that break period. She should start the next pack after the 21 days. No break of 7 days in either case. And she should use additional method of backup in the form of condom or abstinence for the remaining 7 days. And if she has missed 3 or more pills in the first week, she should use emergency contraception, which you will be learning a little later. And what is extended hormonal contraception? The oral pills or whatever your method of contraception you are giving is extended for some time. Then it is called as extended contraception, which eliminates or delays menstruation, and it has got menstrual and non-menstrual benefit. The combined oral contraceptive pills are used for this purpose, and the tablet which is available is seasonal. It's available since in India since 2003. It contains 150 microgram of levonorgestrel and 30 microgram of ethinyl estradiol. Active pills there are 91 in the 3 like you can see there, and they are taken for 84 days continuously with 7 days break at the end of 84 days. And the advantage is that they have got fewer periods, less bleeding. And what are the indications, who are the candidates for that? Women with menstrual disorders or severe anemia, you can go for extended combined pill protection, and adults with puberty, menorrhagia, perimenopausal women who likely to have DUB and menorrhagia, and athletes who do not want to have periods during their cycle, during their games, or women who are in military or in asylum where there are developmentally delayed children or women likely to be sexually assaulted, and any woman who wants to have lesser number of periods because of many reasons. So the advantage, as I told, it is because of the less cycles and less blood loss and more comfort. And the follow-up, how to follow up the woman with combined contraceptive pills. Once after 3 months, we have to call them to inquire about how the adjustment of the dosage, whether there are any symptoms, major or minor side effect symptoms, and to check their BP and weight, and to take look at the breast, whether they're okay, any development of the breast masses, or and to take a cervical cytology. And Yearly, they have to be called after the initial 3 months and 6 months follow-up. Effectiveness is, as we already discussed, it is highly effective, 0.3 for a perfect user. And how long they can continue the tablets? They can continue as long as they want. And ideally, for spacing, they can continue for 3 to 5 years. And a woman in the perimenopausal age group, if they have started, especially with low dose, they can continue till age of 50, till they attain menopause, for the added advantage of protection against osteoporosis and other things. And now coming to progesterone only contraceptives, the available form is the pill, that also called as mini pill. Failure rate with this is a little more than the combined pills, 1 to 3 per 100 women years. Commonly available preparations are Cerazette. It is desogestrel containing 75 milligram. Other preparations are also available. The most common ones is Cerazette. Mechanism of action, as you all know, the progesterone mainly depends on the thickening the mucus, and inhibition of ovulation in 50% of the cases, and tubal motility because of the delay in tubal motility and sperm transportation or ovum transportation. Indications are lactating women and women who are in the perimenopausal age group for the protection against HRT and things like that. And these are the women who cannot use, we can give progesterone, and this is less forgiving. 1 second. Yeah. Contraindications are when the woman is pregnant and she's breastfeeding, definitely, and with women with unexplained vaginal bleeding, we cannot advise, and with history of thromboembolic disorders, active liver disorders, disease with cirrhosis, and definitely we are not going to give. So when to start POP? When a woman it is mainly indicated for lactating women. If she is not lactating, we can start as early as 3 weeks. If she is lactating, after 6 weeks. And combined pills usually are given after 6 months if at all needed. And the advantages and risks are, advantages that it can be given for anybody who cannot take estrogen, but the risk is that it is not as effective as that, and less forgiving, and if she forgets to take for 4 hours, then she has to take additional protection for at least 48 hours. Failure rate is high. And contraindications for progesterone only pills are absolute. In the contraindication WHO category 4 is current breast cancer or past history of breast cancer. Related contraindications are breastfeeding less than 6 weeks and cardiovascular disorders, migraine and liver diseases. So now coming to emergency contraception, this is the most wanted by the method which many of the women who are not using contraceptives, the reliable method, or the regular users, they don't use contraception, they are supposed to know about, like when some mishap happens, then they have to go for emergency contraception. The indications are rape, unprotected sex, and contraceptive failures like condom broke or did not use the method which is expected to use the condom, or IUCD, misplaced IUCD, fallen IUCD, or missed pills, and injections which were missed their scheduled dosage. So in those cases, we may have to advise the woman to go for emergency contraception. Methods available are, as you see here, combined pills, progesterone only pills, and copper IUCD, not LNG IUCD. LNG 11-orgestrel is the most commonly used method. It's also called as Plan B and Plan B plus. Plan B is that 0.75 milligram used 2 tablets. First tablet within 72 hours and second tablet after 12 hours, and 1.5 mg, that is Plan B plus, as a single dose. So it can be used up to 5 days, that is 120 hours, but with reduced efficacy. Copper IUCD is also used as a single IUCD for up to 5 days. Use by method where we use combined pills overall or overall L for up to 72 hours 3 days. Mifepristone is used 10 to 50 milligrams up to 5 days, and ulipristal acetate can be used 30 milligrams up to 5 days. And here in this picture, you see IUCD is the most effective one with 99% efficacy. Next comes progesterone only pills, that is Plan B and Plan B plus, where you have 90% efficacy. And copper IUCD has got the advantage of providing additional 10 years or 5 years, depending on the type of copper IUCD which we have used, protection for another few years, and it is more effective than other pills. Side effects are because they are using tablets, definitely estrogen, progesterone, nausea, vomiting, abdominal, these common side effects you can expect, but they do not cause any abortion, birth defects or infertility in later if they continue to take these tablets. No scheduled follow-up is necessary for these emergency contraceptive methods. And if they miss the cycle, they have to suspect pregnancy, and a pregnancy test has to be done. This is the question commonly asked by the many women. They say that whether they tend to do this. They use continuously emergency contraceptive as and when they want, like a vitamin tablet. So this can be used, but definitely any hormonal preparation will have an effect on the HPO axis, and they tend to have irregular cycles. And when to start the next regular contraception, as soon as they get the regular cycle, next menstrual cycle, they can start with the regular contraceptive methods. So coming to injectable preparations, we have progesterone only injections and combined preparations. Commonly available and used is depomedroxyprogesterone acetate, 150 milligram, that is Depo-Provera, available as IM preparation, repeated every 3 months, and norethistérone acetate enanthate, that is available as 2 mg 200 milligram preparation. It has to be repeated every 2 months. Cyclophile and Misogena, they are combined preparations containing estrogen and progesterone. Currently, they are not used very much and not available in India. So injectable preparations eligibility criteria, like wherever estrogen is not indicated, like adolescent girls more than 16 years of age, nulliparous, obese women, smokers where estrogen is contraindicated, and definitely post-delivery and post-abortion. Mechanism of action is, as you all know, by inhibition of ovulation and thickening of the cervical mucus. Indications, already told, there is no contraindication where it can be used, where estrogen cannot be used. Contraindications are like any other progesterone preparations or hormonal pregnancy is a contraindication, unexplained bleeding, breast cancer, high BP, and breastfeeding less than 3 weeks, and diabetes of more than 20 years, severe liver disease. These are common for all the preparations. And injectable contraception schedule is they can start from day 5 to day 7 of menstruation, and immediate post-abortion, post-delivery up to 6 weeks, and if not, breastfeeding within 3 weeks. This is similar like progesterone only pills which are given in the lactating woman. DMPA, that is depomedroxyprogesterone, given in arms, and Letten given in the buttocks because the dosage is advantages. They're convenient to use, suitable for women who do not want something in the uterus, and they don't want, they have faith in injection and it doesn't interfere with the sex. More than anything, it's a depot preparation. It doesn't allow women to take the tablet every day, and less menstrual flow, and it prevents anemia, most suitable for lactating women. No reduction in milk volume or constitution as it is seen in case of combined oral pills. And however, they should not be given within 6 weeks because of the fear of more bleeding and thromboembolic phenomena, which is common in puerperal women. Advantages are it can be used in sickle cell anemia patients, reduced risk of PID, and protection against endometrial cancer because of progestational effect, and suitable for myoma and endometriosis, prevents ovarian cancer. Complications are these are quoted in few of the research papers. Loss of bone mineral density if they use for more than 2 years, and increased risk of breast carcinoma and cervical cancers. Side effects are irregular, like any other hormonal progesterone preparations. Irregular menses, breakthrough bleeding, spotting are common. On the long run, they may have amenorrhea, excessive bleeding in the first injection, weight gain, headache, all these are. And the not to forget is follicular cyst of the ovary and mood changes and oily skin. These are very, very important to remember with the progesterone preparations. And combined injectables, these are not available. And coming to implants, implants are kept in the arm. These are subdermal implants, Narplant 6, Narplant 2 and Implanon, that is single implants are available. These are progesterone preparations and the mechanism of action, indication, contraindication, side effects are all same like progesterone, only pill or injections, but the implants are placed in the arm. So Narplant 6 contains 6 elastic rods, each containing 36 milligram of LNG. Daily releases 50 to 80 microgram for 1 year, then for another 5 years it releases 30 to 35 micrograms. Insertion under local anesthesia, day 1 to day 7 of menstrual cycle, immediately after delivery or 6 weeks after delivery. And it is in the arm or forearm, small incision is made, and under local anesthesia this has to be. They're very invasive and people don't go for this except in some parts of India. Still we get women coming with these rods, but otherwise in most of the Indian cities they don't go for this. Especially this Narplant 6 and Narplant 2, they prefer to go for single rod, that is Implanon. And the mechanism of action is like POP. Eligibility criteria is also same, and disadvantages is that it requires a trained personnel, and irregular bleeding, all these are same like any progesterone hormonal preparation, injection or tablet. The specific disadvantage is that infection and hematoma at the place of insertion, and removal may be difficult. And this is the one Jadel or Narplant 2. This is similar to that, but it has 2 rods and it contains levonorgestrel, which releases at 30 to 35 per day. So Implanon is commonly used because it is only one rod which can be kept easily, and it is rapidly reversible. Advantage is that decreased menstrual bleeding, good for a person who do not want something in their uterus. And risk is like other progesterone preparations, unexpected bleeding and menstrual bleeding is highly variable. Contraindication, women who is taking anti-epileptic drugs and inability to manage their unpredicted bleeding. And coming to the rings, we have vaginal rings which are combined form and levonorgestrel rings which are only progesterone form. And Nova ring is the one which contains estrogen and progesterone. Estrogen 12 microgram of ethinyl estradiol and 12 microgram of desogestrel. It is inserted for 21 days and removed. After 3 weeks, take out, clean it and use it again after 1 week break for 3 months. And it has to be, a new one has to be used after 3 months. So every 3 weeks on, 1 week off, but the same ring can be used for 3 months. And at the end of 3 months, a new one has to be used. Levonorgestrel rings are not used very commonly. It is again used for 3 months. Mechanism of action of Nuva ring is like combined oral contraceptive pill because it contains estrogen and progesterone. Benefits and risks and contraindications are also same like combined oral contraceptive pills. Failure rate is a little more high, 1 per 100 women years. Lasts for 3 weeks, steady state of medication. And theoretically, pharmacokinetic profile is similar to OCP. There is but there are less evidence to support this, but practically it is the same because it contains estrogen and progesterone components. The latest ones in the market are the transdermal patches. The brand name is Arthoevra. It's still not very commonly, very out of the counter, it's not available. Only in selected cities it's available in India. It's a beige colored patch applied once a week. So it has to be applied once a week for 3 weeks, followed by 1 week patch free week, and it has to be applied every week. Unlike the which we can, unlike rings where you can replace after 3 months. Here, every week they have to go for a new one, and they have to apply it over their thigh or over the abdomen or over their back. It contains estrogen, 20 microgram and 150 microgram of norgestimate. It releases hormones for 7 days and gives protection for 7 days. Indication, contraindication, mechanism of action, all in all are similar to that of combined oral pills. And the mechanism of action, as it is similar to that of combined pills. The advantage is that only once a week. We need not remember to take every day like pills. And the specific ones are like it may cause rash or irritation at the site of administration and associate higher serum levels of estrogen. However, it has not been correlated with the increased risk of VTE. Hypertension and allergy to the components is the another side effect. Newer contraceptives are the newer male pills that is available in the market and not used very commonly. Gazipal is a male pill and extracted from cotton seed. Oral pills available as 10 to 20 milligram daily for 3 months and then 20 milligram twice weekly. This inhibits spermatogenesis by acting on seminiferous tubules, and side effects are fatigue, decreased libido, hypothalamic paralysis. So it is not very popularly used by men. Female newer tablets available are Saheli or Centroman. It is a selective estrogen remodeling membrane receptor. And it contains ormeloxifene taken for twice a week, for 2 weeks, followed by once a week until the couple decides contraception. It's also used as emergency contraception. The efficacy of these Saheli pills is still not established to be used as a regular contraceptive, but it is more often used as an emergency contraception. And at the end of this, you should know that there are some concepts which you have to understand. The most effective contraceptive methods are those which require least amount of effort from the user. Barriers which we learned last class, they include cost and availability to give protection. The counseling is essential for any type of contraceptive usage. For proper use of any method is the key to the success. And OCPs are the most commonly used contraceptives and most reliable and reversible methods. Women older than 35 should not use combined oral contraceptives, more so if they're smokers. Depometroxyprogesterone is safe to use for many years, but there is a small risk of reduction in the bone mineral density and osteoporosis. This has to be taken care. And extended cycle contraception is safe to use. There are a set of women who needs extended cycle. And emergency contraception is a form of contraception available as Plan B plus copper IUCD, and most effective one when they miss their pills or unprotected intercourse. And At the end of this presentation, you should be able to answer these questions and solve these cases. So that I have given you some set of questions for you all. So you have to answer these and send it to me. For this assignment for you all. A 19-year-old married 1 month ago comes into your clinic for contraceptive counseling. She plans to have pregnancy after 2 years. How do you counsel her? What is the best choice of contraception for her? How effective is that? What do you educate about its usage? What are the other alternatives? So a 19-year-old, you can go for barrier methods or oral contraceptive methods. Like we can give combined oral contraceptive, that is the ideal for her. And how effective is that? This highly effective 0.3 per 100 women years failure rate, that is Pearl index. And how do you educate her about its usage, when to start, and what about the management of missed pills? What are the side effects? What are the major complications expected? What are the minor complications? And how to manage, when she should come back for the follow-up. She should come after 3 months, 6 months, and every yearly. So these are the questions you have to ask and explain her and counsel her about all these things. A lactating woman, 24-year-old mother, delivered 2 weeks ago, comes into your clinic. If she has come delivered 2 weeks ago and she wants contraception, how do you counsel her? If she is lactating, 2 weeks ago, we have to wait for another 1 week at least. So after 3 weeks, we can start with progesterone only pills. That is the best choice. And if she is not lactating, she can take combined pills after 6 months and POP after 6 weeks. The efficacy is the 1 to 3 per 100 women years. And how do you educate about its usage? It has to be the important thing, which I did not mention when I was talking about combined, progesterone only pills, is that it has to be taken continuously without break. Unlike combined oral pills, where you have the break period of 3 weeks on and 1 week off, there is no off here. It has to be taken continuously from day one to till the last day, till whenever they want the protection. And what are the other alternatives she has? She can go for they have not mentioned how many. Yeah, if she has completed her family, she can go for permanent methods of contraception, or she can go for injections or implants. So anything in the form of progesterone is safely can be used in the lactating woman. Case 3, a 23-year-old graduate student come to see you before her annual exam. She's very busy for exams and travel coming and wants to have fewer cycles. So the ideal method is extended contraception. Extended contraception, it extends for 91 days, where you can give season aid that contains 91 tablets, 84 active and 7 inactive pills. Benefits are lesser cycles, less bleeding, less premenstrual tension, less worries, and more convenient to manage the cycles. The efficacy is a little lesser than combined pills, 2 per 100 women years. And a 28-year-old calls your clinic, condom broke last night. So she wants to use the morning after pill. Morning after pill is the pill which used for emergency contraception. These the pills available are commonly used ones are the levonorgestrel, that is Plan B, and Plan B plus. Plus is that when you use the whole dosage in single dose, that is 150 milligram as a single dose. Plan B is that 0.75 mg, 750 mg and 2 doses, 12 hours apart. And other pills available are combined oral contraceptive pills, 2 tablets as soon as she remembers overall, and 2 tablets after 12 hours. And when you're giving tablets, they have to be started within 72 hours of the emergency, whatever mishap happened. And it has to be repeated after 12 hours. And these other forms available are IUCD, which has got the advantage that it can be used for additional contraception for another 5 years if you are using the regular one, or copper IUCD 380A if you use, it can be used for another 10 years for additional contraceptive benefit. And if she is unable to obtain EC today, when she is the latest she can obtain it and still have some protection against this we already discussed, that she should start as early as possible within 72 hours. And she cannot, if she cannot use this day, she still has 2 more days, but she should arrange and take as early as possible for the better effect. She can use even tablets even after 72 hours up to 5 days, but with reduced efficacy. The efficacy comes down from 90% to 70% if she takes the tablet after 72 hours. And this is about a 40-year-old lady comes into her office with for birth control pill. She really wants to take it because she's certain that she will have no difficulties in remembering the pill, and she wants the advantage of cycle control. However, she travels by air frequently and she's concerned about the risk of thromboembolic events. What additional health status information do you want to know before writing the prescription? About, she's 40 years, so we should ask her about a history of smoking. Her BMI has to be taken into consideration, and history of diabetes, hypertension, and all the indications and contraindications for combined oral pills have to be considered. And if at all she is very adamant that she should take, she is an ideal candidate for LNG-IUCD because it will take care of her perimenopausal hormonal problems, and she can opt for HRT later. But if she insists on birth control pills, she can go for low dose estrogen pills, and she should be explained, counseled about the risk of VTE because of the risk of her the habit or her profession of whatever she travels by here. She is at high risk of venous thromboembolism. In that case, she should take precautions of drinking more water and ambulating, using the stockings on the legs, or take some antithrombotic measures when she's traveling by air. And what are the contraindications for the usage? So we discussed lots about the contraindications for her for the combined oral contraceptives. And the best option for her is to go for either implants, progestational drugs like implants, injections, or LNG-IUCD is the best for her. I think we came to the end of the discussion. Hope you all have understood about combined preparations. Most commonly, you will be given Mala N or Mala D in your theory viva. You are expected to name the product and tell us about the components and how it has to be started, when to start, when to end, and how to manage the missed pills and things like that. And one commonly used question is that if she misses a pill and if a woman becomes pregnant, whether they can continue. Their dilemma will be like whether they have to continue the pregnancy or not. So you have to give them the option. Your duty is to counsel them that as of now there are no research have shown that it is going to cause any anomalies on the fetus. But it's always better to give the choice to them, because sometimes if any mishap, any problem comes up with the baby not related to the usage of either progesterone pills or combined oral pills, they're going to blame you. So you have to put the facts across and tell that as of now there are no studies proven the anomaly risk of combined pills, but it is not our thing to decide. They have to decide and take a call whether to continue pregnancy or not. This is one thing. Any questions or any doubts you can mail me or call me on my number. Thank you. Discuss one,
Wait.